to another edition of Operation Breathe, the Pune International COVID Knowledge Exchange. And today we'll talk about an extremely important topic, COVID in children. Obviously, these are the children are our future, and we all want to be on top of how to deal with COVID when it happens in this vulnerable population. And leading our conversation today is Dr. Bhakti Sarangi from Bharati Vidyapeeth and Dr. Parag Kumar from North Dakota in the United States. Just as a reminder, this is a knowledge exchange. It's not a webinar. It's not e-grand rounds. It is an exchange of knowledge. So we, by design, keep the didactics short and case-based. And today's discussions is entirely case-based. In addition to the cases that the presenters will present, and certainly your active participation in the polling is extremely important because the whole idea is to get your perspective. And we want to hear about your cases and things that you want to bring up. So please feel free to use the chat function as the speakers are speaking. And then even afterwards, raise your hand, put a question on the chat, we'll call on you. So remember, this only works when we all teach and we all learn. And this involves a lot of people. It's the primary goal is for physicians in the Pune area who are on the front lines of COVID. This conversation is of you and for you and by you. And we're ably assisted by Bharati Vidyapeeth faculty, alumni of AFMC Pune everywhere, physicians everywhere on the front line of fighting COVID. We already heard from Japaigo and the capacity building activities they're doing. And Echo India is providing the platform and making this whole thing possible. I want to also give you a shout out for the next week. Next week, we're going to talk about an extremely important topic, COVID vaccine, same time, 1 week from now. So I'm going to stop here and stop sharing, and I'm going to request Dr. Bhakti Sarangi to please take the lead from here. Dr. Sarangi, please.
Hello, everyone, wherever you are. I'm just going to get right into it and start sharing my screen.
Dr. Bhakti, you're on mute.
Just to everyone?
Yes.
Right, so we'll jump right into it. We'll take you through a series of cases and then have a few discussions and polls. So this is a very practical scenario. The first one, we have a 6-month-old baby girl who has no underlying problems, is previously well, exclusively breastfed, has a documented fever in the peak of the COVID pandemic. She has a documented fever of 101 degree Fahrenheit with some nasal congestion. And the father's tested positive about a week back. Her mother is a doctor, has received 2 doses of the vaccine and remains asymptomatic. So my question to everyone here is, what do we do in this dilemma? Do we go ahead and test the baby? Do we hold on to the testing, just give symptomatic treatment, considering that this is possibly COVID, considering the transmissibility of the new variant? Put the child on oral antiviral medication, considering that she's symptomatic, or admit the baby to the hospital for observation?
So we have launched the polls. I request you to give your answers.
Right. So this scenario was a very typical one that we saw as pediatricians in the second wave and the first wave as well, but a lot more in the second wave because of the high transmissibility of the variant that was causing infections in entire families. Now, this is a situation where you have a child who's symptomatic, but with mild symptoms of fever, nasal congestion, otherwise well, right? This is in the peak of the pandemic where the testing burden on the lab is very high, and which is causing a lot of issues. Now, looking at the scenario, in all probability, with the this child has probably got COVID-19 infection, considering the father is also COVID-19. So, would testing really help? Is the one question in that situation. The other thing is that even if this child is tested and found to have COVID-19, there is no role of giving any oral antiviral medications in this scenario, considering that this is otherwise normal child, well child, and just because she's an infant doesn't really increase the risk of a severe infection in her. There are no clinical features to suggest any lower respiratory infection or any organ dysfunction. And symptomatic care using paracetamol, nasal decongestants, etc., would be the ideal way to go. No role of zinc or vitamin C or vitamin D, any of those things. I feel just monitoring the child at home, monitoring the saturations, etc., would be the ideal way to go. And if it was an older child, or maybe even this situation, counsel regarding the slightest possibility of MISC later, which is obviously very, very low. But these are the things that I would ideally recommend in this situation. Test the baby or not, depending on circumstances, resources, the burdens on the lab, etc. But in the peak of the pandemic, this would, such a situation, you would pretty much consider the baby to be positive. This is a paper that we had published last year talking about the epidemiological and clinical characteristics of COVID-19 in Indian children in the initial phase of the pandemic, and we basically came to the same conclusion that children were still doing better as compared to adults. So mild disease did not require really any interventions. I'll go to a second scenario now. You have a 4-month-old baby girl who is asymptomatic. The mother has tested positive for COVID-19 this time. This is a bit of a role reversal. And the mother has mild symptoms. She breastfeeds the baby and gives her to the mother-in-law. And both the grandparents are at home. What would you do when this parent contacted you? Should we test the baby, isolate for the grandparents, give weaning foods? No need to test, keep the baby with the mother, monitor for symptoms, admit the baby to the hospital for observation, or give the baby some prophylactic medications like, say, zinc or vitamin C or any other thing that you could share.
Thank you for your participation. That's extremely important.
Right. So I think what's important here is to give the right guidelines to the parents or the family for isolation. Right. Baby has no symptoms. He's asymptomatic, but obviously we know that this is a 4-month-old baby girl who's been in very intimate contact with the mother. In all likelihood, could be positive. If she's asymptomatic, I mean, again, there the question arises of testing, because it wouldn't make a difference because mother and baby will have to isolate together. So you have to explain that the risk of severe disease in the child or in the infant is far lesser, and you would rather isolate with the parents themselves. So they have to isolate with the parents, especially in infant. And we have to understand that though the disease risk of severe disease may remain, I won't say negligible, but far lesser in children as opposed to adults, the risk of transmission is definitely non-negligible. So in this situation, definitely with the mother being positive, I would still isolate the baby, considering she's on breastfeeds also with the mother. There is no question of isolating with the grandparents. This was a routine thing when parents tested positive, they would send the child to the grandparents' home without testing very often, and or send them to the neighbor's house or a friend's house, etc., which is not a good idea because the grandparents would have comorbidities. Obviously, age is a risk factor, and they would be at risk of severe disease if they get the disease from the child. So this is a scenario where guidelines for isolation have to be provided very appropriately and ensure that the baby or the child stays with the mother or with the parents and isolates there, and monitor the child for development of any symptoms, in which case you might take some action. So, and even if you do test the child, we know that a negative RT-PCR would not essentially rule out the infection. The virus could still be incubating. So those are things that we need to consider while giving isolation advice to parents who will contact us in this scenario, because these are two very, very common scenarios. Right. I'll go to a third scenario where you have a 1-year-old girl weighing 10 kilos, has come with a documented fever of 100°F and cough for 3 days, followed by fast breathing. She has a pulse rate of 160, perfusion is all right. She's tachypneic. She has a bilateral wheeze on auscultation, and SATs and room air are 92%. On chest X-ray, she has no lung parenchymal involvement, plus a little bit of hyperinflation. And the nasal swab tests positive for COVID antigen. So we know this girl has acute COVID-19 infection for sure. How should we manage? Would you give oxygen or high flow, whatever is required, and maybe steroid? Should we consider remdesivir in this situation? Is there any role for just oxygen and bronchodilators? Avoid steroid, avoid remdesivir, or just go for the whole group together? Give oxygen, use remdesivir, give steroid.
So we encourage questions to be put in the chat box, or if you want to share your story or some comments, you can talk by unmuting yourself.
So a little virus-induced wheezing with COVID-19. We saw a few kids last similar picture with virus-induced wheezing in COVID-19, and they had none of them, I mean, even if they were older, none of them had any positive predictive indices for an underlying asthma. Though asthma is a risk factor for COVID-19, severe COVID-19 illness, we've not had too many reports of asthmatic children doing badly if they got COVID-19, etc. But here in this case, this is another way of presentation of COVID-19, where it does cause a virus-induced wheeze. The consideration obviously is to manage oxygen or high flow is definitely without question something you will use, because you need to support the organs. Right here, you have some involvement of the airways you need to support. In case of the wheeze, bronchodilators, maybe, I mean, there's always a divided opinion on use of bronchodilators in illnesses like bronchiolitis, etc. But steroid is something that you may consider in this scenario, considering the child has is hypoxic, has a moderate kind of disease, acute infection. Steroid is something we would consider. Now, remdesivir again would possibly divide opinion. I'm sure Parag sir would definitely come in on this later, and we can have a chat about it. Remdesivir would divide opinion considering the age of the child, and we know that beyond 3.5 kilos, it has been given. Compassionate use has been granted, and it has been used. Some reports have come out, but numbers not big. But we'll maybe chat about that later. But definitely oxygen, organ support and or high flow if required, and steroid is something I would consider in these children. Remdesivir in our children we have not used, but I'm sure the experience in other places would be different, so we can have a chat about that. Right. This is a fourth scenario, again, very common clinical presentations of viral infections. This is a 2-year-old boy, has a runny nose for 2 days, has a mild fever to 99°F. Parents are complaining of noisy breathing and a change in voice. The child is otherwise feeding well, is active, and on examination has a pulse rate of 124 per minute, respiratory rate 36 per minute, has a suprasternal subcostal retractions and an audible stridor. Now, this is something you don't see in the adults a lot, I believe. Obviously, you see it very commonly in children. SATs in room are 92%. Chest radiograph is otherwise normal. Initial impression is a very, very common viral illness that we see with kids in this age group. And again, the nasal swab test positive for COVID-19. So this is another presentation of COVID-19, clinical presentation that we have seen in our practice, and there have been a few cases coming from across the world. The reason I'm including these different presentations is because if we're anticipating more kids coming with different types of illnesses because of COVID-19, this is what we're going to get or we're in for. Now, how should we manage this child again? Because in routine practice, when we get a child with flu, we do use steroids. We do use in moderate cases epinephrine nebulizations and oxygen, obviously, if the child is hypoxemic. So the question here would arise for the use of both both epinephrine and steroids. And would there be a role for remdesivir, considering again there is no demonstrable lung parenchymal involvement? So these are questions that you would have to answer time and again. So it would make sense if we collated our data, our experiences, and maybe come to some common consensus. So even in this situation, I believe if you've answered the poll, so steroids and epinephrine nebulization both definitely would play a role, oxygen without a doubt, because again, the child is hypoxemic. And these are things we will use. Again, the role of remdesivir is something that is definitely open to discussion in this age group. Without any obvious parenchymal involvement is something I will, possibly look at the polls and have a chat with everyone later. Moving on, it's my fifth scenario. Now, this is a little different. Now, we have an 11-year-old boy. He's obviously got an underlying problem. He's got an acute lymphoblastic leukemia. He's on chemotherapy and has been brought with fever, cough, difficulty in breathing, right? And is definitely tachycardic, has a little bit of tachypnea, rapid shallow breathing, room error about 90%. Family has tested positive for COVID just about 10 days back. And this child has tested RT-PCR negative. However, considering the clinical presentation and a CT is done and a CT score of 14 by 25, which indicates a moderate disease was established, right? So here the consideration is, would you consider this child to be COVID positive or not? And if so, what treatment would you institute? Oxygen or an IV antibiotics? Considering he's negative for COVID-19, you're thinking of other infections, considering he's immunocompromised, or whether you want to give oxygen and steroids, considering he's COVID positive and is requiring oxygen. Or would you consider remdesivir? Is there a role of remdesivir here? Would you consider giving steroids and remdesivir both? Right. So this is a situation where you have a child who's in the peak of the pandemic, has a family who's tested positive, he has tested negative, has clear respiratory symptoms, has lung parenchymal involvement, is hypoxic, has underlying problems, are definitely immunocompromised. With the clinical radiological correlation at this stage, I would definitely consider the possibility of an active COVID-19 infection maybe, and the use of oxygen and remdesivir along with steroids would possibly be a good idea. In case there is a consideration for superadded infection, maybe add an antibiotic in there as well. But that is what I would do. These are all cases that we've had in our scenario. These are all the different kinds of respiratory manifestations that we've seen with COVID-19 in our setting, which is why these cases have come, right? This is my last scenario for everyone. This is what we're all dealing with now. Has created a lot of discussion overall, I think, across the world. A 12-year-old boy, previously well, fever since 3 days, up to 103 degrees Fahrenheit, has abdominal pain and vomiting, has a generalized rash with redness of eyes, is in the ER, lethargic, febrile, tachycardic, is mildly tachypneic, has a white pulse pressure, is hypotensive, and a lot of features of distributive shock. There's no significant finding really on a system examination. The family was COVID positive 1 month back, and the child had tested negative at that point in time, but has now come to you with these symptoms. So my questions here, I have a lot of questions in this subject because this is the one case I'm covering. Is this MISC? Would MISC be on your differential list? Yes or no? And if so, what would you do to prove that this child has MIS-C? What are the investigations that we would go ahead and do for this case? And in case we have managed to answer that, I would like to go to the next slide. And what about the immunomodulation in MIS-C? If you prove that this child has MIS-C, what are the immunomodulations that we would use, considering all the drugs at our disposal? So these are the 4 most common questions asked for MIS-C related to the diagnosis, the investigation, the management, obviously, and even follow-up is something that we may shed light on later. However, now what we need to understand currently is that the scenario that I've given is a very typical presentation of the MIS-C cases that we have seen. It's basically a child who's an older, slightly older child who's come with history of COVID-19 contact about 4 weeks back in the family, though he tested negative. He's got fever, GI symptoms, which are very commonly seen in MIS-C. He's got a rash, he's got mucocutaneous involvement. He's come with cardiovascular dysfunction because he's in distributive shock. And that means if he was in MIS-C, he would be under the severe category considering the organ dysfunctions that he has. And in that state, I would definitely investigate with all of the mentioned investigations. I would definitely do in all the inflammatory markers. I would look at definitely ruling out blood cultures and in the Indian setting, all the tropical infections, because you have a lot of overlap. You have severe dengue coming with hyperphagia, those overlap with these cases. You have rickettsial infections, etc. There's a lot of overlap. That's something you need to rule out. And echocardiography and organ staining is also something that this child would require, considering that he has a severe infection, or sorry, severe MIC in that case. And you would look for COVID IgG antibodies as well. Now, in this scenario, immune modulation, obviously, there is a lot of talk on immune modulation in MIC. These are the 2 definitions everywhere, the definition and the CDC definition. The one very important factor I want to highlight here is that exclusion of other diagnosis is extremely crucial. Because if you look at the criteria for definition of fever more than 30 °F and one of the lab results and at least 2 organ dysfunctions, a lot of illnesses will present like that, right? And because the definition more with the CDC is so broad, it can definitely lead to overdiagnosis. So we need to be very careful about diagnosing MIC, and we need to definitely exclude other infections, right? As far as therapy is concerned, this is a recent article in NEJM, which talked about the treatment of MIC in centers in the US and compared 3 arms, which was steroid versus steroid plus IVIG and IVIG alone. Also considered the use of biologics. Now, they said essentially that a combination therapy of steroid and IVIG, more so in severe cases, would lead to reduced instances of cardiovascular dysfunction. Now, there are still no randomized trials on this. Obviously, this is very new and but something that needs to be done. However, combination therapy of steroid and IVIG in severe cases, at least, or those with requiring multiple organ support, seems to be the evolving standard of care. Mind you, on the same day, there was another article in the same journal which compared, the 3 arms from different, steroid versus steroid IVIG versus IVIG alone, and said that there was no difference, right? So there's a lot of controversy, a lot of discussion on this, and currently evolving standard of care seems to be steroid and IVIG. For the anticoagulation, there are simple guidelines given by the American College of Rheumatology, where if you have a low ejection fraction of less than 35%, or the child is at risk of thrombosis, or has a previous history of thrombosis, or extremely elevated, maybe D-dimers, for which we don't have a cutoff, then we may consider giving anticoagulation therapy. Use of biologics is something that has been reported in case series and reports. We have used infliximab in 2 of our patients. We have also used tocilizumab. Anakinra which is available in the US, has been used a lot and is evolving there as maybe possibly one of the drugs to be used in refractory MISC as a biologic, but it's something we don't have in India. But I think infliximab is definitely one which can I think you know differentiation between MISC or KD, what we that we need to look at because there's initial presentation of MISC in the UK when it was reported last year, there was a lot of overlap with KD. And what we must understand is there are few differences as far as presentation is concerned. Predominantly the age group is different. Kawasaki usually comes in children less than 5 years. Very interesting thing is the different incidences both in similar populations. For instance, we know that Kawasaki disease is widely been reported in the Japanese and Chinese population, but there's hardly any reports of MISC coming from there. Right. And you look at all the other features as well, there are definitely differences. The extent of inflammation is far more in MISC as opposed to Kawasaki, something we must remember. However, when KD is complicated by shock, it's very difficult to really differentiate between two. So to summarize whatever I've said so far, I feel despite the second wave and whatever we're anticipating in the third wave, I feel children still do fare better than adults. The decision to test a child must be individualized, looking at settings, looking at the burden of the labs, looking at the resources available, etc. Isolation must be with parents and not with grandparents or anybody else. Most children with mild disease will require symptomatic care. Steroids and antivirals we should definitely use with caution, and we should always look for presence of other infections. And diagnosing MISC definitely includes the exclusion of other causes. So this is all I have to say for now, and I move on to Parag sir, after which I think it's open for discussion.
Dr. Parag, sir, you're on mute.
Find it. Okay. Can you all hear me now?
Yes.
Good. So thank you for an excellent presentation. You went through a lot of material, which is very creditable. And I'm Parag Kumar. I am in North Dakota. It is like 10 p.m. tonight, northern part of US. And I am professor of pediatrics in the University of North Dakota Medical School. And I'm also a pediatric hospitalist. I was in your wonderful city of Pune from 81 to 85, and I still miss it. Some of my best years of my life. I'm now going to start by thanking AFMC alumni, Japaigo, ECHO team, and our Bharati Vidyapeeth colleagues. And I'm going to read through the case, which I chose to highlight the risk factors and to explore the therapeutics. I will then ask, what would you do? Then we will discuss the evidence. So please pay close attention, and I'm very heartened to see the participation. And I'll ask you to vote in the end. I would like to declare at the outset that we don't have a monopoly on the truth of what we do for a lot of these things in pediatric COVID, and everything is evolving. As Dr. Krishnamurthy keeps reminding us, the aim of this activity is collaborative inquiry and to highlight the emerging evidence about the things that are emerging in pediatric COVID world. So we have this 17-year-old who basically is mildly sick, and he presented to the pediatric ER with fever, cough, sore throat, mild abdominal pain for last 2 days. He has no rash, no vomiting, no diarrhea, and he does not. Oh, my slides going forward or not? I mean, do you see it on the entire screen?
Put it on the slideshow. Put it on slideshow.
Yep, that's what I'm trying to do actually. Give me a moment.
It's on the top, slideshow. No, it's low.
I got it.
Put it on slideshow.
Yep, I got it.
Mm-hmm.
Now you have it?
Yeah.
Okay, good. So he has no rash, no vomiting, no diarrhea, no difficulty in breathing, good oral intake, good output. His temperature was 101.4 today. He does have myalgia and some loose stools, not too bad. No significant past medical history. His up to date with his immunizations, but he has not had the COVID vaccine, which has been available for almost a month now for adolescents. His vitals just indicate probably a mildly sick adolescent who is actually quite overweight. If you see here, his weight is 240 pounds, which is about 110 kilograms. And his BMI is 35. His heart rate is 74. His blood pressure is 130/74. He's not hypoxic, and respiratory rate is 18 per minute. He does have on examination of head, eye, ENT, some rhinorrhea, moist mucous membranes, erythematous pharynx, and his lungs are clear to auscultation bilaterally. There is no respiratory distress. Cardiovascular system is regular rate and rhythm, no murmur, no pericardial rub, no gallop. His abdomen is really soft, difficult to palpate because of obesity, but it's not tender and it's not distended. There are no masses, and we thought he had no hepatosplenomegaly. His extremities do not indicate dehydration. He's well perfused, and his capillary refill is less than 2 seconds. 1 second, Vice.
Go down to the left bottom and the arrow will appear.
Yeah.
Go to the left side, the bottom. Yeah.
So his lab results, actually I have everything on 2 screens, so that's why it's giving me some difficulty. Sorry about that. So his lab results, which were ordered by somebody, and you being a very doctor who is very conscious and who will not waste resources, would not order the labs because you are thoughtful, as most of us would not order in such a situation, got a COVID antigen nasal swab positive, and complete CBC chemistry 7, that is the electrolytes, liver function, PTT, everything is normal. So now here comes the fun part. So we are going to have as many of you who want to vote should vote. Don't worry, there is no right answer. We are using this vignette to discuss the evidence for each of the options. So an obese 17-year-old with mildly acute COVID-19, not in respiratory distress, presented pretty early to you. What would you do? First choice, admit for monitoring. Second choice, maybe do nothing. Third, in US, we have vaccine, the Pfizer one available for 12 to 17. Let's give him the vaccine. He's not let this be a missed opportunity. Let us give it to him. Next is maybe discuss and refer him for monoclonal antibody treatment. Or lastly, don't trust the antigen test and let us send the COVID-19 RT-PCR testing. So we'll give it 10 seconds or more, Dr. Krishnamurthy, and get everybody involved. And I guess I'm unable to vote, maybe because I'm the co-host. So I feel excluded kind of, but I like to chime in because I got it wrong initially.
Can do it.
Yeah, no, it's fun. So let us keep going. Yeah.
Yeah, let's see if we have 67 participants. Let's hear maximum participation in this final poll.
Yeah, absolutely. And like, even if you tell me like something which is like, as we say, we want to learn from you. And I was telling Dr. Krishnamurthy, and we had a very lively discussion that these sessions have been so illuminating in so many places. You guys are way ahead of us. And you have more clinical, especially the session on mucormycosis was like mind blowing. I mean, like the surgeons, I showed it to our team, and the session on long COVID, I am using it for my team, and I'm part of the Unified Command in North Dakota. We are planning a program based on your presentations, Dr. Krishnamurthy, on long COVID. Anyway, that being said, we got up to 37 of 63. Let's see if we can hit 50, So, and let me know when you would like to stop the poll. Surya, yeah.
We have stopped the poll, sir.
Okay. So can everybody see the poll? So let me start by, before we discuss the poll results, let me take this moment to discuss the epidemiology of COVID-19 in our part of the world. The data I have is from end of May. We had 4 million cases in children. By the way, we have 75 million less than 18-year-olds in US, out of which 16,525 were hospitalized, and there were 322 deaths. So this goes against, some people have a belief that children don't get sick and that they don't die. So here is the data that it's not a mild illness in pediatrics. If we didn't have a pretty deep dive in this AAP data, so I looked at it really critically, but I found something really interesting in an end of the year study, the MMWR, which we included up to 21 years old, and they had details of almost every case. And there were 121 fatalities. What was very striking, which is relevant to our case here, is that most of these fatalities were in adolescents and children who had underlying medical condition, and more than half had 2 or more. And the second part was kind of a sad thing, that even in US, disparity of healthcare, like depending on what time of job they have, their parents, are they living in polluted areas, how many people live in their house, what is their socioeconomic status and access to care. So we call them like the social determinants of health. And this sadly is not something that is not seen in US. And 75% of the deaths were seen in these Black, Hispanic, and Native American children, while they make up only 40% of the US population. And believe me, this is not biological. It is something we all need to work on, social determinants of health. So now, this slide that I'm showing you is from the European group, which was published in the end of the year. It basically is a amalgamation of multiple studies which looked at what are the cofactors. And I apologize, it didn't scan very well, but the first highlight is the cardiovascular disease, especially congenital heart disease and cardiomyopathy. If you have that, then if you are more likely to be severely ill or be admitted to ICU or to die, which is not surprising. Same thing in adults. And we also saw that children who were severely ill were more likely to be the ones who had neurodegenerative diseases and cerebral palsy, seizure disorders, uncontrolled asthma. And relevant to our friend here, he who is very obese, like morbidly obese, obesity was a significant risk factor. So going to the next one. So what do we have for these kids? Many of you suggested doing nothing. I think that, and some of you suggested admit for observation. Doing nothing perhaps might be a good answer and might be the correct answer. And we'll explore the other answers. So the monoclonal antibodies are now exclusively available as cocktail. And we do know that if you have a direct evidence of a SARS-CoV-2 infection, either by antigen test or by the RT-PCR, then you are eligible to be considered for this. And how about doing an RT-PCR test in this patient, because we don't trust the COVID antigen test? Maybe that's a moot point, actually. If you see in a high prevalence situation, especially like when North Dakota was one of the worst affected, and what's happening in India, and if you have a child who is symptomatically ill, then it is most likely COVID, then you don't really need RT-PCR. But as I said, that is debatable. What is more important to know is that these patients have to be pre-hospital management. They don't have to be sick, and they have to be fairly early in the illness. And the bottom line in our choice of using monoclonal antibodies is that they should be at risk of progressing to severe COVID-19, which will put them in the hospital or even kill them. So that is what went into our shared decision-making in this patient that I'm discussing here. So on the left side of the screen, you see, I'm sorry if it didn't project very well, obese, irrespective of the age, these are the risk factors. Like if you have obesity, if you have chronic kidney disease, diabetes, immunosuppressive disease, or even of immunosuppressive therapy. And in children, in addition, in adolescents, 12 to 17, like your 85th percentile is like overweight, according to our growth charts, or if you have sickle cell disease or congenital or acquired heart disease, neurodevelopmental disorders like cerebral palsy, or if you are technology dependent. There are a lot of those in US actually. We have like 4% of our population in the US is technology dependent, but they account for 40% of hospitalization in my hospital. Like I'm a pediatric hospitalist. These are the kids who have had tracheostomy, gastrostomy, and who have even been on home ventilator at home, not related to COVID, of course, and those who have asthma or like especially asthma, which is requiring daily treatment. So what is the status in US? In US, actually, we have EUA or emergency use approval for mild and early pre-hospital treatment in adults and anybody more than 12 years of age. And these are all cocktails. And studies in children are ongoing. By the way, actually, they are still enrolling. And these are open arm, non-placebo controlled, because it's kind of unethical not to give them anything, especially when there is evidence that 70% reduction in hospitalization and death has been reported if you can give COVID. In fact, in North Dakota, it was an important part of our armamentarium. So like in India, and one of the purposes of this talk is to raise awareness. Most pediatricians, even in our community here, are not aware of this monoclonal antibodies. But as hospitalists, we offer consultation to our ED colleagues and do shared decision-making, especially for those we are going to be discharging from ED, and especially when our hospitals are so full with COVID. And we use this opportunity to discuss what the data shows in these drugs and whether or not they are helpful. So, not surprising, after deliberation, we decided to use monoclonal antibody cocktail, and it was pretty easy to get the EUA use. The EUA use is mostly for documenting that you are using it, and so that they have a registry and everybody is like following the rules. So how about, like I'm going to just briefly summarize. So monoclonal antibodies are actually useful in targeted and specific situation and works really well. So doing nothing for this patient is perhaps the best, like it is like perhaps the most common thing that's probably followed in US too. But definitely not give him the vaccine, because if you are sick, you should not get the COVID-19 vaccine. And no PCR test is needed. Of course, I discussed why. We could admit for observation if you have the resources and if you have enough beds, but it's not really required, especially you can reach the family and the family lives nearby and they can come back to the hospital if needed. Monoclonal antibody treatment is an option if it is used early, as early as possible, in fact, and in the illness and in mildly or moderately sick. Of course, if somebody is hospitalized or if somebody is on oxygen, then monoclonal antibodies are not for them. So I just keep repeating everything, but medicine is all about repetition. The at-risk kids with comorbid conditions are the ones who will benefit most. You have to have shared decision-making with your infectious diseases specialist, even with your rheumatologist, even with the local resources. Though we don't know the number needed to treat, or as I say, number needed to harm. I'm not really sure if this is available in India or not, but as Dr. Krishnamurthy will tell you, he is a bone marrow transplant specialist, that they do have a role in bone marrow transplant units. And in those where vaccine use is contraindicated, or when vaccine is not likely to be effective, like our organ transplant patients. But definitely, I'll repeat again, it is not for hospitalized patients. It is not for vaccinated kids. And you have to wait for some time if you want to vaccinate somebody who is recovered after receiving monoclonal antibodies. So how do these situations look like? And how do these infusions look like? In our institution, we used Regeneron and this tongue twister Casirivimab and Imidivimab combination, which is basically two things, 600 milligram each. We hang it in a normal saline bag, which is infused over 20 to 50 minutes. And as recently as a week ago, it has been approved for subcutaneous use, especially if you don't have IV access.
A question for you, Dr. Parag.
Yep, and that's the last of my discussion. Go ahead.
Dr. Baljeet.
I'm going to stop sharing my screen and let's see the chat box.
Dr. Baljeet.
Yeah, Parag, I heard you say that you didn't think it was necessary to test this kid for COVID, but yet you wanted to give monoclonal antibodies. So my question was, can you give monoclonal antibodies in the United States when you have a registry without having a confirmed COVID test?
So, sir, if you were paying attention, you would have noted that I mentioned statistically, if in a high prevalence situation, if patient is acutely ill with symptoms which are suggestive of COVID, then it is not necessary. COVID antigen test, not the antibody, is not actually it is acceptable, the COVID antigen test. COVID antibody test is not acceptable. It also depends on which. The Luminex test that we use is very good. So it is not necessary, but RT-PCR is so widely available, so it can be used. But it is a moot point, but we didn't use it. And the FDA, our EUA approval, we got it.
So the reason I say it's not a moot point is because you essentially made the patient out to be relatively asymptomatic, and you even discussed that the patient can be managed at home.
Yes, absolutely.
So he wasn't very severe to begin with. And if you don't have a positive test and the patient is relatively asymptomatic, so much so that you're comfortable sending him home, would there be any indications of giving antibodies even in United States?
So yes, I'll refer you to my slide again. Let me see if I can share screen. And there it is. So in this slide, it says that the ones who are at risk, of severe, like if you see where my pointer is, that confirm that the patient is at high risk, defined as a patient who meets at least one of the following criteria. And our patient at 240 pounds met that criteria in spite of the fact that he was not sick. And if you see here, this is the FDA showing you on the screen. It says that patient has received a positive result of direct SARS-CoV-2 viral testing. An antigen test in high prevalence situation qualifies for that.
Thank you. Dr. Pahade, please ask your question. Dr. Pahade?
Oh, yes, he was asking about the Lambda testing in the chat box. So this is the new kid on the block. We don't seem to be getting a break. It was reported in Peru first, and now we are seeing it in UK. 6 cases were reported. The mutations are actually so far in the spike protein, and it's not increasing the virulence. They are not sure about the transmissibility, and there is no evidence to suggest that the Lambda strain is actually more lethal, or if it is like less, or it is escaping immune surveillance from our current vaccine. But this is like, this news is only a 1 day old. So I'm glad that you asked.
Dr. Manashi Pahade, do you have any follow-up questions? I have a question for Dr. Bhakti about the cost implications for using monoclonal antibody in somebody with mild disease but high risk. Can you expand on that in your practice in Pune?
Yeah, I think there have been a lot of cost implications in our setting, which I think we're all who practice here, all of us are aware of those. So the use of monoclonal antibodies in majority of our patients, to be honest, especially with a mild disease, even with the underlying risk factors, would be a little far-fetched at this stage for us, because those are one of the stronger limitations that we are faced with. And so even, I'll give you, for instance, even with when we had so many kids coming in with the MISC, one of the major problems we were facing was to arrange for intravenous immunoglobulin for them, because that's something that costs a lot. And, even a 5-gram vial costs about 6,500 rupees. So we ended up writing to the government, and we've eventually gotten to a situation where they've granted us a scheme where all our MISC kids will get up to 50 grams of IV immunoglobulin for free. So, but that process was a long one, and it took us some time to convince them to do so. But again, though, this may evolve as some kind of standard of care in children who are immunocompromised and come with these issues, but it still seems a little away for us at the moment in India.
Thank you. I see that Dr. Ivor Jacob is here from the Christian Medical College in Belur, Tamil Nadu. Dr. Jacob, would you like to share your perspective on pediatric COVID at CMC. I put you on the
Thank you.
spot.
Thank you, sir. Um, I just joined, but I couldn't hear the full presentation. So my perspective from CMC Vellore, pediatric COVID as an acute COVID presentation, we didn't have many patients to come with. Sorry, my voice is not very great today. But as you were discussing, we had children who presented with comorbidities who required ventilation. And especially this sort of leukemia on chemotherapy and other patients. And our mortality was very low. But we have got a big cohort of MIS-C, even in the first wave and in the second wave. And they had varied presentations with the shock, as we all know, and the Kawasaki-like presentation, and even MAS. So all three phenotypes we had. And this shock patients also different category, like there were most of them were like moderately shocked with some low dose inotropes, they were getting well. Some even went up to ECMO. So even in the MIS-C group, our mortality was very less, but we could identify them early and treat appropriately. So our big challenge was to differentiate giving immunoglobulin and methylprednisolone in the MIS-C group because of cost implication. So we have got our own protocol and we follow that strictly, closely monitor them. Thank you, sir.
Thank you, Dr. Jacob. Dr. Kinjal, you have a question for Dr. Bhakti, I believe.
Right. So there were diabetes in children during the COVID pandemic. And what I said was that we had a major surge in children coming to us with diabetic ketoacidosis during the last 1.5 years, where we've actually seen maybe 2.5 times the number we get in our ICU. And this surge, we are down this, and this could be obviously attributed to things. About 40% of these kids came with an acute COVID-19 infection. They tested positive for COVID-19. Tested negative. There were many reasons apart. Obviously, there have been a lot of linkages of COVID-19 causing. There have been a lot of linkages between COVID and hyperglycemia in adults, but a lot of this is related to type 2 diabetes. We know that in children, evolution of type 1 diabetes is multifactorial and includes a lot of things, including, genetic predispositions and exposure to the environmental stimulants, etc., and infections. So, however, one of the major reasons a lot of these children landed up with severe DKA was the fact that they had a lot of them did not have access to medical care because of the lockdown. A lot of them had issues with a couple of them had pump failure and could not replace their insulin pumps and landed up in DKA and came to the hospital. Few of them could not see their specialists on time because the specialists were busy doing COVID duties. So, so a lot of these factors contributed to a surge in DKA in the last year and a half. However, on follow-up, even the newly diagnosed type 1 diabetes children on follow-up have remained, they've remained well, but they've remained on insulin. Their C-peptide levels were low. They're all on insulin therapy and follow-up in our pediatric endocrinology OPD.
Thank you. Have you seen any of these patients develop mucor?
No, sir. We none of them actually so far. We had one kid who developed mucor, but this was before the pandemic began. We don't know. I mean, this was about a year and a half, just about 2 years ago. This was before it had set in our country, but none in the last year and a half.
Actually, that's a tribute to pediatricians being very cautious in using steroids. I've been talking to some pediatrician colleagues in India, and it's hats off to them. They are more like the stewardship is way better than for adults, and pediatricians are way more educated than others in handing out steroids. Bhakti did mention that I will touch on the remdesivir question. So remdesivir is also very controversial. For us, we use it very selectively. We use it in a patient who is presenting with bronchiolitis like picture, who is on oxygen and who basically has X-ray positive in your case. It was CT positive and who presented fairly early in the illness, and who is little sick. And that is actually the classical case for which remdesivir has been approved. But that also, when you talk to infectious diseases specialist, when we get a case like this, we all butt our heads together. Half of them will say don't use it, and half of them will say do not use it. Another situation we have, like I distinctly remember, like we had a patient with common variable immune deficiency who got really very sick and was ventilated. And in those cases, like we really throw everything at the patient and whatever we had, and I doubt any intensivist will hold back. So that patient even got convalescent plasma, though we know that it doesn't work. So that is about the status. And it is approved in children like more than 3.5 kilograms, but it is not commonly used. I mean, I remember using it only like a couple of cases in our area, and our intensivist maybe another couple of cases. My question for the intensivist in India, Dr. Jacob, is like, what is the status of your using steroids in patients who are admitted with COVID, and who, like, what is your threshold for starting COVID? I'm a steroids. I'm sure that you're not giving to outpatient ones, but as hospitalist, I'm really keen because that is something like we struggle with here. And now we have seen conflicting data that it might be harmful if you give it when they're not on oxygen or something like that. And some people use DEXA, some prednisone. What is your feeling about that, sir?
Yeah, exactly, sir. See, even WHO recommends those who are with the severe disease and critical disease, those who are on oxygen 2 liters. But in our setup, what we decided, not even those who are on a mild or what we can say 2 to 4 liters, those can be managed in the ward. We didn't give steroids. But those who required intensive care and they required a high flow nasal cannula, or more than that, respiratory support, we started the low dose 0.15 mg per kg of dexamethasone, even though they have admitted probably with other comorbid illness, not really due to the COVID per se as a pneumonia, but we used for severe and critical disease only, not for all those who have required oxygen we didn't use.
Thank you, sir. And how about the, like, are you seeing any problems, like a follow-up, Dr. Bhakti, like the ones that for the MISC, because your numbers are really good. We don't have that high numbers here to follow up. Now we feel that MISC is kind of underreported in US. Even the case definition is high because like if you have an HIV, you get a lab diagnosis and it's easy to report. In absence of one single lab testing and MISC being a clinical diagnosis, most hospitalists feel that it is kind of an underreported disease in the country. But we are fortunate that the results are excellent. So what is your, and we are planning to put in a follow-up program. So the cardiologists are like involved in that. So do you guys have a follow-up program for these to see like we have for Kawasaki?
Yes, sir. We currently have a follow-up program. We've been following all of our cases since the first one we had in, I think, June last year. For 1 year, they've all been following up judiciously with us. And it was quite similar to Kawasaki, actually, initially, the way we followed them up with the, clinical assessment markers, as well as interval echocardiographies, especially in those who had underlying cardiovascular dysfunction or coronary artery dilatation. So we would, there would be a followed discharge day. They would be followed up at week 1, week 2, and then 4 weeks for the first 3 months, and then at 6 months, and then 1 year. This is the program we followed. So far, even the data that I've read and what we've seen with our fairly decent number of patients is that none of them have had any residual abnormalities, even the coronary dilatations and everything else, other underlying cardiovascular dysfunctions, whoever suffered, are doing fairly well. The ones with severe disease who received, the 4 or 5 of them who received biologics, are also doing very well. And there's no clear evidence as of now any residue problems currently.
Thank you. Moving on, I'd like to invite Dr. Pahade. Manasi Pahade, please ask your question. Please unmute yourself.
Hello, good morning all.
Good morning.
So what about flu shots? My question is the kids who have taken it or who are taking it regularly, yearly, are they more protected for this COVID?
So there is no evidence that it will provide cross protection against COVID, but flu being a serious illness in itself, I would say that it is good to take the flu shot.
Dr. Bhakti, are you seeing much flu at all in the lockdown?
No, honestly, when at its peak in the pandemic, we did not see anything. We had one H1N1 case reported during the pandemic in the last 1 year is what I've seen. However, now after things have come down a little bit, our climate has changed. We have more monsoons are setting in. We're seeing a little bit more of other viral infections. One problem here, as far as testing is concerned, that because of the cost limitation, we don't usually, end up diagnosing co-infections. So all our kids, in any case, currently get tested for COVID-19, especially the ones with respiratory symptoms or ones that come with fever. But testing for other viral infections, including RSV, etc., is not a routine policy in our place. So co-infections go undiagnosed. However, flu shots definitely, even the IAP recommends flu shots for the other viral infection. There's no data, like Sir said, to talk about prevention of cross-infection. You can maybe prevent co-infection or just give it to, get rid of the other viruses at that point. That's about it.
Thank you. So the flu shot is protecting against infection. That's not happening. Is that more or less all it does right now?
We even saw a big decline in RSV and big decline in flu. In fact, it was the best season ever in the US memory. And that was basically because of the masking and social distancing. So that all shows that we should still be masking and social distancing because it works.
Thank you. Dr. Baljit Sharma has his hand up. Dr. Sharma?
Yes, the three short, quick questions for you, Dr. Bhakti and Parag, if you want to answer them too. You had mentioned that you would do an echocardiogram in your patient who was very sick. So first question is, how many people have you found with involvement of the myocardium? Second question is, if you do find it without LV dysfunction, does your treatment protocol change? Third, in the same sequence, in case there is LV dysfunction, do you transfer these patients to a center where they can put them on ECMO if necessary? Thank you.
So to answer your first questions, of all the kids with severe MISC that we have admitted to our center, out of all of them, I think about 30 to 35% had myocardial dysfunction, right? And about 20 to 25% had coronary abnormalities. All of these children had documented echocardiography. We do point of care ultrasound bedside, so we do bedside echocardiograms ourselves, as well as we have a full-time cardiologist who functions there. So these children required a lot of vasoactive drugs. The funny thing was the case I mentioned as well in my slides had a clear presentation of a distributive shock, but on echo had also a fairly poor ejection fraction. So we've also seen a combination of these two things. So they've gone on to require vasoactive drugs. They've gone on to require pressors as well as inotropes at the same time. All these kids have responded well. They've all received a combination therapy of steroid and immunoglobulin, though we've been careful giving immunoglobulin because of the concerns of fluid overload in these children with left ventricular dysfunction. From what I've otherwise seen is in cardiac issues related to MISC, I mean, we've seen a couple with some rhythm disturbances. And I think on the whole, a lot of other issues, including pericardial effusion, a lot of them have had valvular dysfunction, which has gotten better. So we've seen a lot of, a whole set of cardiac abnormalities, but definitely 30% or so had left ventricular dysfunction. And so no, we haven't transferred any of them to ECMO center. We've managed most of them. I mean, we've had only one death in a child with MISC who had an underlying, a lot of issues with bleeding, things like that. Otherwise, all our kids have done well. And we've usually, I mean, ECMO itself is, there's a lot of limitations with ECMO at our place here. But most of them with multi-organ support, ventilation because of shock, not because of a respiratory problem. addressing the cardiac output, managing the left ventricular failure with vasoactive drugs, etc. And using our immunomodulation, I think all of them have responded and done fairly well.
Thank
I think
you.
that's a very
Dr.
complete
Shinde,
reply.
you have a question. Go ahead.
Yeah, I see another question. Dr. Shinde has asked.
Dr. Shinde, can you state your question?
Please unmute yourself.
Shinde. Okay, Parag,
So I'll read it. So there is Dr. Shinde is asking a question: if the child is 10 years old and RT-PCR was positive on the 6th June, is it okay to give flu vaccine? The answer I would say is like the similar questions we get asked like in adults, like when do we give them the COVID vaccine? So I'm extrapolating from that, or when do we give any immunization? So we like to wait at least 2 weeks from the first day of sickness. And one reason is very basic, that you have to go to a hospital to get it, and you don't want to be breaking your isolation period and giving infection to others in your zeal to get the COVID vaccine. The second, of course, is that if you have been ill, you recover a bit, and 2 weeks to a month is about a standard practice that we do in adult medicine. And in pediatric medicine, we have not yet started giving influenza vaccine in our part of the world, but we are planning in August to get the first vaccines in place.
Any other questions for the speakers? I see a hand up. Dr. Parag?
Yes, sir. My question is related to previous question. What about other vaccines like OPV vaccine? If my 1.5-year-old patient tested positive in first week of June, and should he take OPV on his due date?
So you can be flexible. You still have to wait it out. Like 14 days is still the minimum for your isolation period to end, so that you're not infectious to others and give it to the healthcare workers. And anywhere between 2 weeks to 1 month, if I remember correctly from the CDC data, you can resume immunization. Children, fortunately, are asymptomatic from COVID infection. And even if they get COVID, they don't terribly suffer from it. The hospitalization rate, as you saw in my cohort, was pretty low, like 16,525 out of 75 million. And that means out of which 4 million were, of course, infected. So I don't know how to calculate that percentage, but it's a pretty small number. So it should be pretty safe to, I would say, like with any other illness, if it is really mild illness, like upper respiratory infection caused by rhinovirus, we give the infection. But here I would probably wait for complete symptom resolution of COVID, or 14 days, whichever is later.
Thank you. I'm going to call on Dr. Sunil Jatana, who's in Malaysia. And can you give us your experience with pediatric COVID, please, as a senior pediatrician there?
Yeah, actually, the problem is that we have not seen any COVID cases here, because we are not managing any COVID cases. We are not managing COVID cases. So I'm just getting educated from the talks, whatever I hear from you people, and whatever I read in the literature.
So COVID in Malaysia, is that?
No, we are not seeing COVID cases here, because in the sense we are not treating COVID cases. The other doctors, the local doctors, the Malaysian, they are treating COVID cases and all. And we are away from there. So I don't have any experience as far as treating COVID cases concerned.
Okay, thank you.
Thanks.
Dr. Shinde, do you want to talk about the Google docs that you're sending? So we've had very few responses. Do you want to talk about that, Dr. Shinde?
Yeah. So hello all. So currently we are collecting some information from all of you to understand your challenges and needs and how we can support you. So we have shared the Google form earlier, but only 11 responses we have received, and 5 are from Pune. So I request you to again share it with your contacts, so that we can make a community and discuss upon how we can provide trainings to your staff. I'll share the link again in the chat box now.
Okay. All right. So Do you have any final messages, Dr. Bhakti, Dr. Parag?
I would say like whenever vaccination is available for kids in your part of the world, go aggressively for it. That is the way out of the immunization. We do recognize that there have been some concern about myocarditis, but that concern is actually less serious than COVID infection in the community and in the kids. And we are actually like 20% of our adolescents are already immunized, and the number is increasing. Thank you.
Thank you. So we hope to see more about, we'll hear about vaccine next week. Next week, Dr. Sanjay Lalwani, is a senior pediatrician and medical director at Bharati Vidyapeeth, and Dr. Monica Vasudev, who's a pediatric allergist, immunologist from Wisconsin, US, will together lead the conversation. So with that, and unless there are any final thoughts from anybody, I'd like to wish you all the best as you go forward, taking care of your patients and taking care of families. Do well and do great work. We will see you again in a week. Thank you very much. Have a good day.
Bye-bye.
Thank you, sir. Thank you all.
Bye-bye.
Bye.
Thank you.